It's my great pleasure to introduce this next panel discussion, which is on overcoming barriers in symptomatic women. This session is chaired by Annwen Jones OBE. Annwen is CEO of Target Ovarian Cancer in the UK, but she's also vice chair of the World Ovarian Cancer Coalition. Annwen, welcome, and thank you so much for chairing this session. With that, I'll hand over to you.
Thank you, Clara, and welcome all to this session. Achieving rapid diagnosis of ovarian cancer is a charter goal that I feel very passionately about because of the crucial opportunity that it gives us for more women to be well enough to receive treatment, to tolerate treatment, and for that treatment to be more effective. We've heard in the first session about the barriers to rapid diagnosis that exist in primary care, and work that can be done, is being done to address this. And we're now going to focus on what is known as barriers to presentation. So what are the factors that influence the time it takes between a woman first noticing symptoms and her seeing a doctor to have those symptoms investigated? What are the barriers? What can be done to support women to seek help with their symptoms more quickly? And to discuss this, we have an excellent international panel drawn from our member organizations. We are joined by Andrea Krull from Ovarian Cancer Germany, by Adia Kabangeli from Campaigning for Cancer in South Africa, and by Vandana Gupta from the V-Care Foundation in India. They are all doing the most fantastic work in their own countries and will each bring, I believe, very important, but also very different perspectives to the discussion this afternoon. So thank you all so much for joining us. In addition, the coalition issued a short survey to understand women's experience of diagnosis, and we hope to reflect some of their insights too over the next 40 minutes or so. So I'll be talking to our panelists in a short while. But first, I'd like to introduce Dr. Christine Campbell from the University of Edinburgh, who is a health services researcher working in cancer and primary care and in global health. Welcome, Dr. Campbell, and thank you so much for joining us.
Thank you and good afternoon. It's a pleasure to be with you in this important session and afternoon.
Thank you. Dr. Campbell, your research has primarily focused on barriers to symptomatic presentation of cancer and screening, both in the UK and in countries such as Malawi. I wonder if you can tell us whether there are barriers to presentation of cancer that are common in most, if not all, countries.
Yes, and I think it's important to start with that recognition of the universality of the challenge that there can be for women. Some are around awareness of symptoms and their potential seriousness, as was touched on earlier on in this afternoon, including the non-specific symptoms that Willie and Garth were speaking about earlier, particularly for women post-menopause. We know our bodies change, and understanding the importance of these is something that if there's limited literacy or health literacy in particular is important. I think language used in consultation with a primary care provider, again, is pretty universal. Sometimes clinical guidelines can be quite technical and use language that the GPs or health professionals will slot. This is a potentially serious disease or diagnosis, needs referral. But that might not be the language that women use when they're describing their symptoms. And I think that's a gap that we need to work hard to address and to reduce, particularly from the professional perspective. I think of fear of cancer. Fear of cancer is universal, doesn't matter what context you're in. Fear of the side effects of treatment will come in a moment, I know, to whether you can afford these or not. But these can be barriers, particularly to older women who may remember some of the very debilitating treatments that a previous generation received for cancer. And the legacy of that can be quite profound. And I don't want to have to deal with that, and can delay presentation. Fatalism can be stronger in some of our more deprived communities, and some shocking stories that GPs can tell of people in their 50s who feel they've had a good innings. I've heard GPs in the UK speak like that of patients who had a cancer diagnosis. So that fatalism, again, can be universal. And multiple demands. A woman may not prioritise her own health in any healthcare context. She's busy with family responsibilities, whether that's children or an older generation, and working to support a family or herself. These are universal things that I'm sure the panel will pick up on.
Thank you. That's extremely useful. And kind of moving on from that, are there some barriers, additional barriers, in low and lower middle income countries?
Well, and I look forward to the discussion in a moment, but that will vary by country and context. And just to add in, that's why local research is so important, to understand the context that any of us work in, particularly with a global audience as we've got today. But I think there are some things that from the literature and my own experience, my own work internationally, can be quite pronounced. Fatalism, again, can be important. Normalization of a shorter life expectancy can be very prevalent, and also a question about whether the health system can do anything. In many countries, the health system can be weak and resources very stretched. So is there even a belief that something can be done? I think stigma can be a huge issue. There's certainly stigma in many countries, but we know in many low and middle income countries, the stigma that can be associated with cancer, fear of being ostracized by your family and community, perhaps divorce from your husband. And what I found in some of my own work is a double burden for women living with HIV who then have a cancer diagnosis. The stigma associated with HIV, a huge amount of work has gone in, and I know our colleagues will be able to speak to this, to try and reduce that stigma, but it's still there. But I have certainly had women in qualitative work in countries in sub-Saharan Africa say, I'm dealing with HIV, we're learning to live with this. How can I now have a cancer diagnosis? And so that can act as a huge barrier to presentation. Issues of finance. Many of us are blessed to be in countries where there's universal health coverage, but where that's not the place, or where health insurance is very expensive, then the cost associated with every single appointment, transport to a health facility, far less any subsequent diagnostic procedure and treatment, where families may have limited income, feeding your family and schooling of your children are priorities, may deprioritize a woman's health-seeking behaviour. And I think in addition to that, many countries and in many contexts, women may be more used to going down an initial route, at least of traditional or complementary medicine, and seeking help from there first before the health system and a more clinical health systems followed.
Thank you very much. So we have these common barriers which already are pretty significant, and we can talk perhaps later about some of the interventions that we've tested in different countries to address those, but there are some even more significant barriers in other countries. I wonder whether I can come to Adia. I wonder if I can come to Adia, and whether you can comment on the situation in South Africa, on what Dr. Campbell has said, which of the barriers kind of resonate with you, and what work you do in your country to seek to overcome them and help women get a rapid diagnosis.
Hi, thank you.
Hello.
What Dr. Christine has mentioned is true. We are currently dealing with that. We have a patient advisory board where the main function of the board is for patients to provide that invaluable perspective to stakeholders and provide about how to make improvements with the goal of better serving all patients. So in the board, we have come up with issues such as patient delaying the appointment due to transport because there's just a long queues and they're unable to be on time. And also regarding the fear of not knowing what they might have or wasting the doctor's time. But the biggest issue we currently have in South Africa is the transport system. And because of this, we have partnered up with Uber to assist cancer patients with safe and essential transportation to and from treatment. Thank you.
That's fascinating. So you've established a partnership to overcome what is quite an important systemic problem for you, and you've partnered with Uber. Can you tell us a little bit more about how that came about?
We actually heard the patient. It was actually cervical cancer patient in our WhatsApp group who raised an issue of her how she felt unsafe taking taxis while going for treatment. And because here treatments are not one day, they are either 30 days or 60 days, and they don't have enough transport. And sometimes they might miss the treatments. And because of that, we decided to partner up with Uber to help us assist patients who were struggling with transport.
Thank you. And I'm sure that others might have some more questions about that partnership, because I think, you know, that is a very practical response to a seemingly a very difficult problem. And that could be a response that could be replicated in other areas. Can you, in your country, can you tell us anything about, is there a stigma around ovarian cancer specifically, or cancer in general? And is that widespread or not a problem with you?
No, we do have stigmas happening here as well. We heard issues actually from the cervical cancer PAB, and one of the patients spoke about how when she got diagnosed and she was told that she had cervical cancer, and the Black community they kind of like linked it to her being sexually active. So they were thinking that she has cervical cancer because of her going around and sleeping around. And those are kind of the stigma we face here in the Black community. And because of such issue, we decided as well to hold media briefing, which is an educational session for media utilizing key opinion leaders, healthcare workers, patients, and survivors in a discussion about cancer to provide better outcome for those recently diagnosed or those living with it. And in there we get testimonials from such story, just to break the stigma so they can share to the media, so they can have the right information and share it with the public.
Thank you. Thank you very much. So that awareness is clearly a really important part of your activity. Could I turn to Vandana, who is with VCare Foundation in India. Do you have similar challenges?
Thank you very much. I would like to start from the beginning, in the sense, in India, we have a very big divide of urban area and rural area. It's about 10% of the country is urban and 90% of the country is rural, which is what really affects the quality of treatment and the diagnosis and awareness amongst the various types of cancers. Having said that, I would like to tell you that for ovarian cancer, the ratio and proportion is the same, whether you are in the rural area or in the urban area, which means everywhere the problems exist. So to talk about what Dr. Christian said and what Adia said, it's the same thing. If you start with stigma, there is a lot of stigma. People don't want to talk about it. Ladies don't want to talk about it. And then it goes on to divorce and other things that she mentioned. Financial status is a huge problem. We don't have any government schemes. Everything is done only because of what is your ability to pay. It's only in the last 2 or 3 years that some government schemes have come out where you can be treated on that, but there are restrictions on the amount of money that can be given, and also that the entire like suppose it's a targeted therapy, you will get medicines only for a week, for which you have to come to the hospital, get admitted for a day, take that 1 week medicine and medication, and then go back. Which means that if somebody is living in a rural area, they have to travel every week to come to the center, which means expenses are involved in that. So that adds on to the problem. Often when the doctors are talking to the ladies and the families, there's no clarity in thoughts, in the sense they do not understand that they cannot use medical language or the medical terms to talk to the people, because they cannot think in terms of talking to a communication is a big barrier, because they do not know how to talk to a patient. It's always talking about big words which people will not understand, especially when education and lack of understanding is a big issue. So all these things I think are common everywhere. Now the one more thing that comes up is that in India we have a lot of problems, because people always, all the symptoms that are associated with ovarian cancer, especially, are things like abdominal, discomfort and all that. And people presume that it is something to do with the stomach, which is a huge problem. And so they begin to treat the stomach rather than thinking of ovarian cancer. And then what happens is that, we have various forms of treatment, like the Ayurvedic treatment, or we have a local doctor, not doctor really, he is somebody who will give you some concoction of medicines to say that these are the best medicines to have. They may be just powders and some herbs and other things. So people start taking treatment on those lines. So by the time you come to realize that it is ovarian cancer, you are almost always in stage 4. So all our cancers are always diagnosed in stage 4. Very rarely do you come in stage 3, never, almost never in stage 2 or stage 1. And this is the situation all across the country.
Thank you, Vandana. And from your point of view, how do you think about where to start in improving the situation? I mean, what are the key factors for you in terms of kind of a strategy?
I think there has to be a lot of awareness and education. And we have been thinking, we have ladies in the villages who are called the ASHA workers, ASHA, which is a term for healthcare workers who are working in the villages. So if they are educated more, just now they're taking care of basic emergencies and pregnancies and gynecological problems, etc. But if they can be educated on the early symptoms, and in fact training the people or educating the ladies in the villages or the families that every stomach problem or every abdominal discomfort is not a thing which has to be just looked at as a stomach ailment. It can be something else, and that is what will really take care of things. And also the fact that if it is ovarian cancer, it doesn't mean that you are not a complete woman, because very often people think that if the ovaries are going to be removed, then you will not function as a woman. The children and all may have already happened, because it's normally above 50 years that this issue comes up. But even to function as a woman, people think that you need to have your ovaries. So if these ladies can be educated about these small things, and while they're talking to the people in the villages, they can, talk about it. And I think one more thing which is very important is having pictorial, representation of the disease, of the symptoms, of everything else, which can be put in the doctor's clinics all over. So if I've gone to see a doctor and I see these symptoms and I realize that I'm having similar symptoms, maybe I will myself become more alert to my body to going for a checkup for ovarian cancer rather than wasting my time on abdominal things. Like I've heard in UK, if you have any discomfort in the stomach for 1 or 2 weeks, then they start doing your CA 125 and other tests. So if I'm conscious of it as a person who has seen these pictorial warnings, maybe I would ask my doctor, even if he has not realized, that I would like to have a CA 125 done. So that is the education I think that needs to be done without scaring people, without putting a fear in their mind.
Thank you. And you kind of touched on a number of themes there about awareness, about support, empowerment, language, and non-verbal language. I was just wondering if I could bring Dr. Campbell back in again, and whether Dr. Campbell has any reflections on what both Adi and Vandana have talked about.
Thank you both. I think you both describe your local context and also the challenges, the issues of stigma and support. Speak not just to education of the women, but actually community empowerment, community engagement, so that I think particularly with cervical cancer, because that's what I work most closely with in Malawi, the need for education of men about disease, about health, and so that it is seen not just as a woman's problem, but it's seen as something that can be dealt with as a community, and community sessions and awareness sessions that deal with health more holistically, I think are important. I really like the approach that you mentioned, Vandana, in relation to the ASHAs, because the closer education comes from people that women trust, the better. There's often such a gulf, and it's true in any setting, but particularly where the literacy and health literacy is lower. There's often such a gulf between a health professional who's been trained and is very well dressed compared to women who may be in very rural agricultural settings, and that distance can be very intimidating. And peer education, someone who is from your own community and trusted, makes such a difference. So I think that's a very powerful tool, and I hope that goes well, and it's one that can be adapted and adopted for other contexts too. Certainly the power of having a peer educator, as you were talking about different stakeholders, Adia, in your setting, to share stories, the survivor stories, to say that you needn't stigmatize me. This happens to ordinary women. We're not evil. We're not sexually promiscuous. This hasn't come as a curse from evil spirits, but this is something that's sadly a normal part of human experience. Anything that can normalize, I think, is important. So thank you both.
Thank you. I'm going to move on to Andrea. I can't see Andrea at the moment.
Thank you.
Hi, Andrea. Now, you're in your situation in Germany. You're in a very, very different situation when it comes to diagnosis. Your circumstances are almost the mirror opposite of the UK. So here we have a real problem with late diagnosis and poor 1-year survival. And that's why the work of target ovarian cancer is kind of so focused on that. But once women are diagnosed and they get into the health system and they get treatment, they get excellent treatment, and we compare very well to other countries there. Can you tell us why do you think that women are diagnosed more quickly in Germany?
Yes, the reason is that gynecologists play a quite important role here in Germany, because you are supposed to go regularly to a gynecologist, even though if you are a young woman, young girl, yeah, and therefore they are at least checked once a year with their gynecologist, and this is a regular paid agreement with our health system. But anyway, sometimes gynecologists have not the knowledge about ovarian cancer symptoms as much as cancer symptoms. You know, this is a big difference in numbers as well, and therefore even women or young women do not know the unspecific symptoms, and therefore the conversation about it and the recognition is not really done. But all together they are more often checked and controlled by gynecologists than everywhere, I think.
And once women are in your system, once they've been diagnosed, what are the challenges? I mean, what happens next? What you know, for the rest of us, we're thinking if we can just figure out a way of, you know, encouraging women to present early, and you know, getting doctors to refer them quickly, then, you know, we will have made a substantial inroad into the problem. So what happens next for you then, in terms of how treatment is organized?
The problem is, if a woman gets a diagnosis of ovarian cancer, she is referred usually to the next hospital, which is local, you know, but there are some few very, very high level excellent centers for ovarian cancer here in Germany, but they are not local most of the time. And there is a problem. The surgery and everything on the local hospitals and doctors is not quite well trained. They are good. No critics here, but it's sometimes better to get referred straight to Berlin or to Essen, which are the excellent centers here in Germany. And here's the problem, that as well the doctors and the woman do not want to travel for a proper diagnosis or proper surgery.
And what do you see as your role in trying to change that? I mean, have you been
my role is first of all is my role to get the unspecific symptoms in awareness campaigns, you know, as well to connect patients and doctors together to talk about ovarian cancer, and as well to educate women and young women in quite nearly in school, when they are 17, 18, about the symptoms of gynecological illnesses. You know, this is a key for me, that young women should be trained as well to ask questions their gynecologist when they are uncertain about certain whatever illnesses or behaviors. This is important, and this is my role.
Thank you. And and yes, congratulations on all the work you do. You were there at the launch of the Every Woman study, I recall, and spoke very powerfully then. There does seem to be a very strong common theme running through what Vandana has said, what Adi has said, what Andrea has said about education more broadly around women's health, and what we all need to do in our different countries, because those issues, they exist everywhere, even though the challenges in some countries may be greater. That we need to think very carefully about that. Dr. Campbell, you mentioned earlier, and I might just finish off on this point because I want to move on to COVID before we close, but you mentioned earlier about the importance of research doing research and gathering evidence. And I wonder whether you could just expand on that and with any kind of pointers, perhaps, for people who are listening in to this call from various countries as to.
Yes, I mean, I'm a health services researcher. I've been involved in evaluation of awareness campaigns here in Scotland, but also thinking about what's going on with countries that I'm involved in. There is nothing, local research is powerful. You need, in a few areas, I think it's important to be able to influence policymakers within your own country. It's no point saying in Britain they've got this lovely piece of research, or in Malawi if you're in South Africa, or if you say something from Bangladesh if you're in India. We all need research that's relevant to our local context to shape and to advocate to policymakers, to politicians, to our ministries of health, regional directors. But we also need research to understand what's going on in our own communities and what their needs and their fears and their awareness is, so that as we're designing information campaigns, that it's using the right language and it's addressing the needs of our own communities, because otherwise we could be addressing something, we could spend a lot of time talking about fatalism, when actually the big issue is stigma or the very practical issues of transport. So to my mind, that's where research matters. And somebody this morning was speaking about the importance, or earlier this afternoon was speaking about the importance of partnership. And I'd just like to back that up, because we need to move out of silo ways of thinking, whether we're academics or clinicians or community advocacy groups. Let's do what we can to link up with our local colleagues, because we're much more powerful then at being able to understand what's going on. But I would say about research, do it well. There's no point in doing poorly designed research. That's almost worse than no research at all. Work with local universities, local colleges, design good questionnaires and surveys, work with the coalitions and the cancer groups locally, so that there's more power in well-designed research, and happy to work with the coalition if there's anything I can do to direct you towards relevant colleagues.
Thank you. And I'm hoping that we'll be able to continue this conversation, because I feel we've just kind of scratched the surface. Before we finish, I would like to talk about COVID. I mean, we've seen in the UK this week, data were published that showed that 44,000 fewer people got treatment for cancer from April 2020 compared to the period before the pandemic. And sadly, I think this will be the case in many countries. Dr. Campbell, can you just describe the impact of the pandemic specifically on the diagnosis of cancer?
I think it's devastating. I don't want to overplay it, but I think in all our contexts, Willie Hamilton did say earlier, the NHS is open for business, and it is, but there is no getting away from the fact that resources, quite rightly, have been pivoted to deal with the COVID emergency and in vaccination. Diagnostic capacity has been limited because of pivoting of staff, but also all the infection prevention measures that have been critical to keep patients safe when they do come in, has meant that the ability to treat the same volume of patients has been reduced. So Willie has talked about the impact on late stage diagnosis and then survival. So I think it speaks to the importance of continued investment in diagnostics and workforce capacity, using the smart software, triage, etc., that we talked about earlier this afternoon. I think globally, our colleagues will be able to speak to this all from their own settings. The world economy is going, there's no getting away from the economy of our world is going to be affected, and therefore the prioritization of governments into the ministries of health, and how that trickles down then to the health facilities that women visit, can't be ignored. And the role of advocates is going to be critical in coming years to push that, and to say, don't lose sight of us, even in the middle of trying to get vaccination rollout and to redress other issues that have come up.
Thank you. And I would like to go to the panel for their observations on this. Vandana, could I come to you first about the impact of COVID on diagnosis in
Yeah,
India?
definitely, because most of the resources were to COVID, and also the funding that we were receiving for towards helping cancer patients was given into the government fund for COVID care. So the funding stopped, and though the one of the biggest hospitals in Mumbai, which caters to cancer patients and other hospitals, they kept their door open for treatment. But people were not able to reach. The transport was a problem because it was an absolute lockdown. There was no accommodation available for those who managed to come, and there was no food available because all the shops had closed down. So, even for coming for treatment, and of course, the fear that if they were traveling, then and if they catch COVID, what would be the next thing to happen? So there were a lot of problems, and I think the repercussions of this late diagnosis, almost no education and awareness creation, and everything will be seen after about a year or two, because as it is, we get cases in stage 3 and 4. So now I think it's going to be almost metastatic disease that will come into the thing. So, I mean, I can't say now, but I think in the next 1 year, we would know exactly what the situation is, and it can't be good anyway.
Yeah. And there'll be a big backlog in the system too, won't there? Adia, how is it in South Africa?
And the biggest challenge were especially found on patients who were trying to get the test done to know what they currently are having. Because of that, they were unable to get hold of the lines in hospitals. They were not directed into the right pathway on how to get assistance. And such issues were raised in the patient advisory board. And because we have patients in there who have gone through that situation or are currently going through it, we also have a dedicated nurse who were able to assist those patients. But in terms of treatment, at the beginning of COVID, there were some delays. There were some delays on that. But in the meantime, we are still providing transport for those going to treatment every day.
Oh, fantastic. Oh, it's it's not a good picture, is it? And then Andrea, what information do you have about the fall in diagnoses in Germany, or impact on treatments?
This depends on where you live. It is really a problem sometimes with local hospitals, and it is quite delayed, the diagnosis and the treatment as well. But all together, it is quite good. It's not that bad as in other countries. Yeah. The problem here is that women have to force the entrance into the hospital and to force to get in and to get a diagnosis. This is a problem because often women are not really strong enough on this point because they are insecure, or they are they are overworked, let's say, with all impressions they get primary to the diagnosis. And
Thank you.
COVID is difficult to get in hospital.
Yeah, so the problems that were already there have been increased several fold because of COVID, and the message is that there will need to be a substantially increased effort as we come out of it to make sure that women come forward, and there will be a lot of women with more advanced disease, as Vandana has said, and hopefully there will also be some more positive developments, particularly around telehealth, that may help us going forward. I want to thank you. Unfortunately, we do have to come to a close. I want to thank each of you for an incredibly powerful contribution to this session. I think for us to be able to understand the complexity and the variation, the variation in the experiences of women in various different settings. There are challenges. Just to synthesize, we've heard about the need for greater education, empowerment, awareness, advocacy, data, research. And I think what's really positive, just hearing from all of you, are hearing about what actually is possible and all of the innovation that you're driving in your countries. And I think that will be really important as we as a coalition go forward. You know, what happens in one country is not replicable in another country. And Dr. Campbell made that point very clearly, but we have so much to learn from each other. And so I thank you very much indeed. And I would like to hand back to Clara McKay at this point. Thank you.
Thank you, Annwen. Thank you so much. And really, just to echo what you've said, what an amazing panel discussion and how interesting, you know, the issues that came up. And I'm struck actually by, you know, how much we share in common across countries as we differ. It's very interesting, actually, so much in there. So we have, and I think Frances is going to join us here. We have 5 minutes, really, probably about 55 minutes too short to reflect on today. And it's been such a rich session, just, you know, really interesting, you know, from the potential for a single pan-cancer test, you know, I think Frances said you know, taking something like CA125 that's, you know, cheap and been around for a long time, but now we see it in potentially a new light that could be, you know, so helpful, and everything from, you know, award-winning GP programs through to just, you know, what's happening on the ground and innovations with Uber to help, you know, tackle some of those very, you know, practical problems. Our poll, we don't have a huge response, so it's not a huge sample, but I think most significantly, 0% or 0 of the respondents said that in their country, they did not experience any practical barriers to diagnosis of ovarian cancer. So no one in no country, in terms of our delegates, feels that they've, you know, kind of managed to iron out all the barriers. A lot of feedback about women not realizing the importance of their symptoms, doctors not recognizing the importance of their symptoms. So really reinforcing what we heard. But if I could turn, and maybe Frances, I'll start with you. I believe you're with us. I just wondered, okay, you know, from the work you've done pulling this amazing event together, are there a couple of takeaways that really stood out for you? And do we have grounds for being, do you think, optimistic about moving the needle when it comes to more rapid diagnosis of ovarian cancer?
I hope so. I really hope so. I begin to think we are beginning to see the signs of the potential for progress. What we have to make sure is that progress is available in as many places as possible. I think the thing that has struck me throughout this, you know, the determination it takes to work in this sort of area, to understand what is going on, to work out what is your problem in particular in your country, in your setting. You need to find your biggest barriers and work at those first, and that is really important. And I know from work that I've been involved in just how long that takes. And it's not just about raising awareness of the symptoms, but it is about overcoming the stigma. I mean, Adia talking about the media briefings that they do. I remember going back 15 years and being told, oh no, it's too depressing, we don't want to cover it. Or if we are going to cover it, can you find a woman who's young and good looking to be the face of ovarian cancer? And, you know, a lot of attitudes and things that have held things up and get in the way, and they're so important to work at, as well as, you know, the symptoms knowledge and the doctor's knowledge. In our survey before the event, again, there was a sort of equal split between women saying women need to know more about the symptoms and doctors need to know more about the symptoms, because it's all well and good going to the doctor, but if you keep being pushed back, then you're not going to get the diagnosis to then be able to access the new treatments.
Yes, I think determination, persistence. And I was actually quite struck, I think it was Dr. Wint that said, you know, in her clinical career, she would see, you know, maybe very, very few women with ovarian cancer. So I think really understanding how we can empower physicians as well as women to really work together to, you know, act on what they need to act on when they need to do. And when same question to you, really, you know, what stood out, and are you feeling optimistic?
I think we're in a very different place, certainly in the UK to where we were 10, 15 years ago. And Francis referred to that in terms of attitudes towards ovarian cancer as a silent killer. In terms of the outcomes, we now have much better treatment options. We may not have a screening program, but we have got a whole new generation of treatments of PARP inhibitors that make it more important than ever that women do have the earliest possible diagnosis in order to access those treatments. What struck me actually, certainly in the latter part of the session, was what I have always known, but it kind of really came to the fore. It's the power of the patient advocacy groups. It's the power of the patient voice, and that has more influence than anything. You must do the research, you must have the data, but unless you've got people who are determined and persistent, I think persistence is the key thing. It took us 10 years to get a national TV advertising campaign from the government in the UK, but we got it. You know, we do have it in our power to drive change. Some of it takes a long time. Some of it can happen quite quickly if you have the right data, actually. So I'm optimistic because I think we have got people, not, you know, the challenges notwithstanding, we have got people here who will drive this.
Couldn't agree more. I couldn't agree more. And I think we can look, you know, to other areas and you know, like breast and HIV/AIDS, where, you know, the patient advocacy movement moved mountains, literally. And, you know, and so I'm with you. I would not underestimate the power. And I think going back to something Christine talked about, the power of those partnerships, which it really stands out for me. Thank you again, Annwen, and thank you, Francis, and thank you to all of the contributors and delegates and sponsors